Right, I think we will get started. A very warm welcome to everybody. Welcome to today's webinar, the second in the series of webinars that Oviva has been running. This webinar today is titled Using GLP1s in a Digital Pathway to Deliver a Cost-Effective Weight Management Solution. So very warm welcome. My name is Karen Miller. I am a diabetes dietitian by background and work as one of the clinical leads here at Oviva. And I am your chair today. And as you can see on your screen, we are joined by my amazing colleagues, who I will let them introduce themselves as they get nearer to their speaker slot. I don't think I could possibly do them any justice, but we're delighted to have them here to come and share some of their expertise and their experience with us today. Little bit of housekeeping before we get started, just to let everyone know that this call today is being recorded. Please, can you make sure that you are on mute? We will have chance for questions at the end, hopefully, if I can keep everyone to time. So you will have a chance to unmute yourself if you choose to. But in the meantime, if you could please pop yourself on mute. And I think other than that, there is very little other housekeeping we need to do. So we can move on to our agenda for the day. So we're going to look at our introduction. We're then going to set the scene with our obesity challenge. We're going to have a look at how Oviva's digital tier 3 weight management solution might be a really exciting option to explore, as well as that the GLP-1 pathways via a digital option as well. And then if I can keep everyone to time, some questions and answers. Please feel free to pop your questions in the chat. We won't interrupt our speakers as they're speaking. We'll create time for that at the end. So if a thought comes into your mind, feel free to pop that in the chat. We do have some questions that were pre-submitted, so we'll try and prioritize those as well. Thank you. Right, so for those of you who are less familiar with Oviva, let me introduce you to who we are and why we do what we do. So we are one of the leading providers of weight management services for the UK, and our mission is really simple, but really powerful and close to our hearts. We want to provide the most accessible and effective care to people living with weight-related conditions through our cutting-edge digital technology. But alongside our digital tools, we have an amazing clinical experienced team who are there to support your patients. And we work in a variety of fields. We have a good presence in diabetes prevention on the national framework for diabetes prevention as well. We support patients who have been diagnosed with diabetes and try and give them the power and the tools to be able to go and live well with diabetes. And most recently, we've really become experts in helping to put people's diabetes into remission with a really great presence on the framework for T2DR. But we are here today to talk about our Tier 3 weight management program. And that's why I've been joined by my experts to help me do that. Our services are set up by our experts based on fantastic evidence. And as a result, I have a really good presence. We have got a presence across the whole of the UK now in 76% of ICBs. We have 62 publications with really, really exciting, impressive Tier 3 weight management outcomes, which Lucy's going to touch on some of those with you today as well. We've seen more than 200,000 NHS service users since 2016, and we look after each of those with such care, and we are so proud of the journey that each of those people have been on as well. So enough from me in terms of just letting you know who Oviva is. I'm going to hand over to Sam now, who is going to unpick this huge obesity challenge.
Thanks, Karen. Hi, everyone. I'm Sam. I'm the head of strategic development at Oviva, and I'm going to talk to you about the obesity challenge. Next slide, please, Holly. Thank you. We have some shocking numbers to share with you today. We're currently at about a quarter of our population is obese and a further third overweight. So add that up and it's to 64% of the total population. And these rates have doubled over the past 20 years, so it's increasing as well. And it's causing some pretty dramatic end effects. So we know that obesity is associated with 80 to 85% of the development of type 2 diabetes. It's the second leading cause of cancer behind smoking, and it's further associated with 200 other diseases, including causing heart attacks and strokes. And the end effect of those complications and of the disease is that it ends up costing our system, 19 billion pounds a year to our NHS every year. And when you wrap in the societal cost to that, it's equivalent to 4% of GDP. And all in all, this means it's too late for a prevention alone strategy, and we need to be treating more people. The problem with treatment is we have a severely supply constrained system for the demand that is out there. So we have 35,000 places for 4.2 million eligible people. And so that means it takes us 120 years to treat everyone, which obviously is not sustainable, and it's going to perpetuate the problems that we identified on the last slide. The other issue with this is that it risks a two-tier system from emerging, where only those who can pay for treatment can access it, which is not what we want. So yes, to sum up, obesity sticks out like a sore thumb in our preventative healthcare system. It's a chronic disease, and so we should treat it like other chronic diseases. We don't see these patterns of non-treating in any other chronic disease, so we shouldn't see them in obesity. The prevalence and healthcare costs are enormous. It's too late for us to do prevention alone, and our patients are struggling to access treatment. And so we believe that digital is a key way to unlock this, to properly serve this population. And I'll let Lucy and Tom tell you a bit more about our digital solution. Over to you, Karen. Thank you.
Thank you, Sam. Thank you so much for setting the scene. And this is a challenge, and it's not a small challenge. So Lucy, I'm really looking forward to hearing how you feel Oviva has a potential solution to help with this huge challenge.
Lovely. Thanks, Karen. Thanks, Sam. Can you hear me okay? Just a quick sense check. Perfect. Cool. Thank you. So good afternoon, everyone. I'm Lucy Diamond. I'm Clinical Director for Innovation here at Oviva. I've been here since the birth of Oviva UK, so back in 2015, 2016. I'm actually a diabetes specialist and obesity specialist dietitian by trade. Worked for almost a decade in the NHS prior to joining Oviva. I promised to stop with my CV, but just to give you a bit of a reassurance with hopefully some of the commentary around our diet and lifestyle intervention as a solution today. I'll start by setting the scene about weight management services and nice guidance, but I acknowledge the wealth of experience on this call today, so I'll only touch on this briefly. Then I'll go into a deep dive about Oviva's digital solution within the arena of Tier 3, before I hand over to Tom, who will take us further into our pathways around GLP1s. So to kick off, I'm sure we're all familiar with the tiered approach here that we're seeing in weight management services, acknowledging that obesity is a highly complex condition. So there we have at the bottom of the pyramid as our foundation prevention services. We have bariatric surgery at the top. Then we have Tier 2 and Tier 3 services straddling the two layers in between, with Tier 3 supporting people with complex obesity, requiring a really specialist MDT approach. And here we have the nice guidance for Tier 3 services and some of its recent iterations and additions of GLP1s. So a Tier 3 service must have this MDT, multidisciplinary team of healthcare professionals. The service should be available for individuals based on BMI, as listed here, but data tells us that the average BMI for individuals accessing a Tier 3 service is actually around 45 to 46. GLP1s were introduced as a treatment option for weight management back in 2022, alongside a Tier 3 service. I should make sure that's caveated, and with the addition of Wegovy added into the mix in the latter half of last year. So Sam presented the challenge to us earlier on. The number of people living with obesity is staggering, and services purely cannot keep up with the demand. So the NICE EVA, so early evaluation assessment, aims to support issues faced by the NHS and patients, such as high demand of services, lengthy hospital waiting lists. It does this by reviewing and recommending digital technologies, devices, diagnostics, therapeutics that can support remote monitoring and benefit from digital innovation. So last year, we saw NICE's EVA explore the role of digital therapeutics in weight management, especially weight management with medication. And Oviva were listed by NICE EVA as one of the 5 digital weight management technologies that can be used in the NHS to deliver specialist weight management services for adults who are eligible for weight management medicines, which leads me nicely on to talk more in depth about digital solutions. So whether you're 100% in for a digital solution, if I get my word out, or yet to be persuaded, I want you to really have a think about your own personal digital use. We've gone a bit fancy this time around with the ability, you should see a screen, the ability, if you scroll down to answer some of these questions. Sorry to ask you in your lunch break to get active with answering, but I've got a few quick fire questions for you around your own personal use. So do you have a smartphone, yes or no? And our next question, scrolling down, have you ever intentionally, that should say, left your smartphone at home? Oh, I love the honesty. Fantastic. And then that's a nice split, actually, more than I thought. And then our last question, have you ever used an app to track your fitness or your health? Wow, incredible. That's a great split. So a high percentage of people on this call do have a smartphone, intentionally don't leave their phone behind any moment of the day, and have used an app to track their health and fitness. So when we're making decisions about our diet and lifestyle every minute of the day, why not use a tool that we have at our fingertips every minute of the day? So thinking and moving on to that digital solution, that digital pathway, what does that actually mean? And I thought no better place to start than me asking ChatGPT, what does that actually mean? And this is the definition they came back with, which is pretty spot on. A digital pathway in healthcare is really there to streamline and enhance the delivery of healthcare services, involving improving communication, improving data management, decision-making, and overall patient health. So summed up in a nutshell by ChatGPT. Which leads us on to talk about Oviva's digital solution. So the key headline here is we combine real humans. It's not purely digital technology we're talking about, especially in the realm of tier 3 and complex obesity. We're not expecting someone to go down a digital pathway on their own. So here we're combining real humans using digital tools to maximize engagement and ultimately maximize outcomes for patients. So in the human camp, we're led by healthcare professionals, and our humans use a technology to deliver that patient care and effectively manage large caseloads. On the patient side with the technology, it's primarily our app, which we're trying to drive engagement on our pathway, on our programs, and improve the patient outcomes, their goals. Just to briefly touch on our app itself, it's embedded in behaviour change tools and techniques. We have a team of 100 professionals, engineers, content producers in-house working on developing our app. And I have to say it is led and produced by healthcare professionals with patient input. In between the human contact, our app is there to support goal and habit formation. It also provides instant feedback to keep people engaged, keep people on track, and features such as our diet suggestions, which use smart algorithms, and in the coming months, we'll be using AI in that arena too. Self-tracking really is at the heart of what we do with our digital tools, with some lovely recent literature really showing that the more people track, the more weight they lose. Also to touch on, we have extensive, reliable and trusted content written in-house by our healthcare professionals to really guide that individual on their journey. So think personal guides mixed with Netflix, you have read, so we recommend. So you know that we now use humans and we use digital tools to deliver our care, but what does our tier 3 service here at Oviva actually offer? And it really is a personalised approach with 3 key potential pathways. 1, diet and lifestyle intervention, the plan tailored to that individual. 2, diet and lifestyle plus the option of an 8-week total diet replacement approach. And number 3, now in our toolkit, is diet and lifestyle plus a GLP1. And to note, we are one of the only digital providers that is CQC registers and has that experience of prescribing GLP1s in the NHS since May 2022. Just to note as well that all the participants get triaged and assessed for psychological support, which is provided by our psychology team. And all participants get access to the digital tools we've been speaking about and resources. But there is an option for a phone pathway if they don't have a smartphone, like some of the people on our call today, or face-to-face, depending on the area it's been commissioned. I've used the word humans and spoken about humans, but who are these humans? Actually, highly experienced experts in their field of weight management. So here at Oviva, this is our MDT. We are consultant-led by Dr. Wasim, and we're run by our medical lead, nurse prescriber, psychologist, and specialist dietitian you can see on screen. Majority of them are on the call today with huge thanks, because I know this is a bed review and MDT day, so you'll have not had a break yet. So thank you so much for joining and supporting. Here we have a very detailed overview of our program, and I promise this is not to go into too much detail, send you all to sleep and wish you hadn't joined this in your lunch break. It's more just to give you an overview and a headline to showcase really the intensity and frequency of support an individual gets over that 12-month period or the 24-month period if they're on a GLP-1. To kick things off during their enrolment, we really try to learn as much as possible about the individual, and patients are then reviewed at our weekly MDT. Our start phase is where participants kick off with initial consultation with their dietitian and or their psychologist, and here their pathway of choice is discussed and agreed upon, as I mentioned before, with those 3 possible options. During our change phase, participants have intensive support, whichever pathway they've opted for, and Tom will really deep dive into that GLP-1 pathway very shortly. Sustain is all about learning those lifelong skills to maintain weight loss. And at this stage, we may have people returning to an eating pattern post a total diet replacement, continuing a lower carb or a SMART goal approach, or reaching their 4-month mark on a GLP-1. Final human interaction is at 12 months or 24 months if they're on the GLP-1 pathway, but access to the app is lifelong for self-tracking, reviewing of goals, nudges, and continued updating with our learned content. Final few slides from me. As I touched on at the last webinar, does it work? Does a digital solution work? We've been delivering Tier 3 weight management services since 2018. And as I mentioned, GLP-1s were introduced in our pathway back in May 2022. And to date, we've had 10,000 patients referred to us. We've got a great uptake of our services. On average, across the pathways, we're seeing 8.2 kilogram weight loss at the 12-month mark, and that's around 6.5% there. We're seeing improvements in anxiety and depression scores. And finally, we're seeing that people would recommend us to their friends and family. And final slide from me, breakdown of the different pathways that I've touched on. Here we're seeing 7.7% weight loss by our more traditional weight loss approaches. If we add a total diet replacement into the mix, we're seeing 11.3%. And on our GLP-1 pathways, we're seeing 11.8% at the 6-month mark. Just to note that GLP-1 outcome percentage score there at the 12-month mark is Saxenda. So we really hope to see this figure further increase with the addition of Wegovy. Last point from me is when we look at the GLP-1 arms and the pathways, we see around 12% weight loss with Oviva support plus a GLP-1 versus 8% with GLP-1 alone when we've trialed this in our Swiss data. So, in the words of Tom from our last webinar, I hope I showcased that diet and lifestyle interventions are certainly not dead, and a digital Tier 3 solution could be supporting the increasing demand, especially with the addition of GLP-1s. And that's all from me. Over to you, Tom.
Thank you, Lucy. It's really lovely to set the scene about certainly the importance of that lifestyle intervention, despite this exciting next phase of obesity management that we're kind of working our way into. So on that note, Tom, I think it's over to you to share some of Oviva's insights into how we've managed to deliver GLP-1s, but remotely. So over to you, Tom.
Thank you very much. Thank you very much. So yeah, nice to meet you. If we haven't met before, I'm Tom Curtis, a GP by background, still work in the NHS as a GP, but also work with Oviva in the role as a bariatric physician, and also act as the CQC registered manager for the service. I think initially it's always good just to translate this GLP-1 acronym into something more real. So I'm just going to review this again for 30 seconds, 60 seconds. So GLP-1s are a hormone we all produce when we eat any food, and the food can be consisting of anything: carbohydrate, fat, protein. It all stimulates a GLP-1 release from the gut as it goes down our intestinal tract. And that GLP-1 hormone goes off around the body and does a wide range of things to our physiology. But the one we're really interested in terms of the new drugs is the latching on of this GLP-1 to the hunger pathways in the brain. That seems to be the primary way these GLP-1 therapeutics are working. So the GLP-1 hormone acts as a brake on our hunger drive. Now our native GLP-1 we produce naturally when we eat, sits at the receptor site for about 90 seconds, maybe 2 minutes before getting cleared away. These GLP-1 therapeutics, they latch on for hours and more recently days to these GLP-1 sites to really put a handbrake on our hunger for a sustained length of time. And via that mechanism, that's why we see the weight loss outcomes with these novel, exciting drugs. And they are exciting. I think their efficacy has been proven beyond doubt in the very large studies, but they're not without their problems. And one of the principal problems is the side effect profile. And because of that, patients dropping off the treatment before really the value is derived in terms of the weight loss and preventing diseases like diabetes coming along. And we're going to look at some of our persistence data because I think that's very interesting. But it will, on our next slide, we'll just have a look at what we've been doing over the past 18 months or so with regards managing our Saxenda cohort of patients. I think I won't talk through every arrow here, but I think the key points to make are, it's fully aligned with the NICE criteria that was set out by NICE in terms of managing and checking eligibility for Saxenda. We've taken an individualized approach, so patients could have a flexible run-in period without the drug, in terms of the length and also the dietary approach they take. And we're very lucky to have a workforce of GLP-1 experts, so diabetes specialist nurses who've been using GLP-1 medicines in the diabetes space for a decade or more, providing one-on-one consulting with patients who are considering a GLP-1 therapy. We then built in touch points where we knew patients might be having a peak in their side effects before they start to settle again. And we also wanted to build in patient-initiated follow-up so they could get hold of us if there was any particular problem. Once everything's been proven, they were proven as a responder, they're getting on well with the drug, we then build in touch points at 3 months for the second half of the prescribing period. But again, patients can contact us on an as-needed basis should any problems crop up. And then we look after the patient for the full 24-month GLP-1 journey. So we're going to look at some data as to what's happened to those patients, but that's the pathway that's been built on and what the data has come out of this pathway, as it were. We just go to the next slide. So this was a novel pathway. We were an early adopter in terms of managing GLP-1s digitally and remotely. So we had to just underpin it with some foundations to ensure, firstly, it was safe, because there wasn't really a prototype to copy. And that was informed by the GMC's remote prescribing high-level principle, because although remote care is certainly nothing new now, managing these injectable therapies was, and so we wanted to be highly robust. And reassuring for us and hopefully everyone else is CQC have also externally examined these pathways and no concerns at all with regards to the safety of what we're doing. And then layered on top of that, we wanted to build in interventions that would really drive adherence. And a lot of that comes from the app and the MDT that's been presented previously. But we wanted to think about how we could initiate successfully these treatments, again, being mindful that this is an injectable treatment. Most of the patients will have never had an injectable treatment before. How we do that in a remote way that's acceptable and builds confidence. Managing the patient through the titration steps of these GLP-1s, and then having touch points to drive persistence so that we maximize the value of the drugs that we do prescribe. So on the next slide, we're just going to look at the initiation, because although we've developed these pathways, we built what we could from the evidence that existed, it was still not 100% certain that patients were going to feel confident or accept this as an approach. So we took an internal survey that we presented at the UK Congress on Obesity actually this year. And I think the data speaks for itself. So as a result of having our expert prescribing workforce, combining it with bespoke written materials, videos, offering video or phone call options to bring in third parties as we counsel patients through the initiation of these treatments. The vast majority of patients were either confident or very confident at the time that they received their Saxenda prescription to start treatment in a way that you'd think would be hard to beat in any other modality of consulting. On the next slide, that's a summation of overall satisfaction with the pathway. So this is the whole obesity journey plus the Saxenda. And again, I think the graph speaks for itself in terms of the satisfaction that patients have, which is wonderful, but we also wanted to get some more objective measures as to whether this was driving good outcomes. And Lucy's presented the weight loss data, which is very, very encouraging. What we've got is now some persistence data coming up, because as I say, one of the big problems with anti-obesity medications of all types, and still in the new injectable therapies, is patients not staying on the treatment. So they'll drop off because of side effects or expectation hasn't quite met reality. And on the next slide, we'll see Oviva's and our pathway approach seems to be driving good persistence with these treatments. The first thing to point out is those red lines. That's the enforced stopping rule with Saxenda. So as most of you may know, after 12 weeks of being on the maximum dose, you have to assess if the patient's lost 5% of their body weight. And we know 3 to 4 out of 10 will not. There'll be non-responders with Saxenda, so you automatically get a drop off there. So that's an enforced dropout, as it were. Outside of that, if we compare with all the other real-world data that's available for liraglutide, that is Saxenda, compared to a very recent study that's also plotted on the same graph, Oviva has 2.7 times the retention of patients on therapy. And when NICE considered the real-world evidence in its evaluation, the technology appraisal, the study they looked at and pointed out by Novo was a 26.6% retention on these drugs at 15 months. And again, we compare very favorably with that. We know that the dropout after 6 months is much, much lower, so that we can probably extrapolate our 12-month data forward to the 15-month, and there'll be very little difference. So again, very pleasing retention, and I think really is an objective measure of how confident and satisfied patients are with the journey that they're on the pathway. We go to the next slide, please. So in the Wegovy era now, that's a slightly kind of retrospective look at what we've been doing, but I think it has proven some fundamental points that the pathway is highly acceptable to patients in its current iteration. It seems to drive persistence and good use of these medications so that patients, let's say, derive the downstream values of disease prevention. So we think we've got a model that is in no way broken, and we've translated a lot into the Wegovy model. There are a few differences that's just worth pointing out. The run-in period is slightly shorter now because there isn't the same evidence base for having an intensive dietary run-in beforehand to drive weight loss. But we still have a dedicated behaviour change and lifestyle focus without the drug, so that patients are onboarded and know that that's a key part of their ongoing obesity management, which is always lifelong. We have the same touch points, which have driven good persistence. And again, the arrows for continuing behaviour change and lifestyle throughout are very important. We'll continue to look after the patients for the 24 months. We've also strengthened our MDT because, as we saw, we now have Dr. Wasim in a substantive consultant post for us. Wegovy, because of its broader criteria as per NICE, we're going to have slightly more complex patients. So having that consultant endocrinologist on board is really important to maintain safety and ensure we can manage patients in an absolutely optimal way. So just in the summation, if we go to the next slide. So we were an early adopter of digital remote GLP1 pathways, which is why we've been collecting a lot of internal evidence and presenting at a lot of conferences and congresses with regards what's been going on with our GLP1 cohort. Our internal persistence and qualitative data with regards to satisfaction, I think, is very, very satisfactory indeed, which does suggest that a digital and remote approach can therefore be a big part of this capacity puzzle that these new GLP1s have thrown up. So that's it from me, and I'll hang around for any questions, but thank you. I'll hand back to Karen.
Thank you so much, Tom. And I think you've stimulated so much extra discussion because loads of questions have started to come in. So that was really, really useful. And thank you very much to Sam, Lucy and Tom for not only setting the scene of how challenging this is, but helping us to understand some of the potential solutions as well. We have time for some questions, which is brilliant. That's exactly what we'd hoped for. And you've heard so much from our experts now. We really do want to give you guys a chance to voice your opinions and your thoughts as well. What I'm going to do to start, you can see some questions have come in on the chat. We had some questions pre-submitted as well. So I'm going to work through those. And then if anyone would like to take themselves off mute, we're really happy to encourage some discussion once those questions have been answered, if we have time. So our first question that came in, I think, was from someone who has joined our call today. Michael Titmus, you raised a really, really valid point, highlighting that there are a number of barriers and uncertainties in Tier 3 weight management services. They're under-resourced. There's a huge problem, just as Sam kind of drew out right at the start of our webinar. Now we're adding in this added complexity of the injectable medications where there's a huge demand for it. So your question is, do Oviva view themselves as a standalone competitor to current NHS Tier 3 weight management services, or as a potential adjunct, integrated element in existing service pathways? Do we want to work collaboratively with the NHS, or do we see ourselves as that standalone? So we would be delighted to answer that question. I'm going to direct this one to Lucy, if I may, Lucy.
Yeah, sure, of course. We come in peace, Michael, I promise. We only, if it's a reassurance, we only deliver services to the NHS. So we don't deliver care privately, we don't offer self-pay options, and it depends the area of service, in all honesty. So we work really closely with either face-to-face providers that are established within the NHS, and we are there as their digital solutions, so to help with the demand, or to help with people that aren't accessing face-to-face for barriers or limitations that may prevent them from being able to access their face-to-face service. So we can either work in partnership, and we do in many places with trusts or ICBs, and offer that flow of referrals back and forth between the face-to-face provider, or if it's an area where there is no service, we could offer the full bells and whistles and in that setup. So we come in peace. I wouldn't say we are a competitor to NHS services. I'd say we are there as a suite of offering to be added to NHS services to improve access to care. I hope that answers the question.
We know there are a lot of patients to go around, don't we? So we're really happy to support in any way that you might feel that we can do that. So thank you, Lucy. That's great. Tom, you did allude in one of your slides to the stopping rule, when we make that assessment that this medication is right. We've had a question come in. I think our consultant helped to answer this perhaps in the chat, but Tom, your thoughts on the guidance on how long is it safe for patients to take Saxenda or Wegovy?
Yes, that's a good question. And I suppose no one quite knows the definitive answer to that, but there is, as per their licensing, there's no upper limit in terms of continuation. But obviously we're, as we're an NHS provider, hamstrung, or not hamstrung, we're bound by the NICE guidance, as it were, for the 2 years. But there doesn't seem to be an upper limit in terms of the safety. I think potentially with the new wave of GLP1s, they're going to be so effective, potentially you will drop down to a BMI at which it does not make sense to particularly continue on the full dose. But again, this is an area-free zone at the moment. And in the diabetes space, obviously GLP1 therapeutics are open-ended in terms of how they've continued. But so I'm not providing, I don't think, a definitive answer because one doesn't exist. But I hope I've kind of touched on something that resembles an answer in that.
Thank you, Tom. So we're still learning loads, aren't we? And this is one of the important reasons of being able to capture this data and monitor these patients. We want to ensure their safety. And we do know that these medications are available out there on the black market, and that's not how we want our patients to receive this care. Thank you. We've interestingly had a shift in focus in questions, and as Lucy mentioned, we have a whole MDT available on our call today. So I'm actually going to call on our lead clinical psychologist to answer our next question, because this is a really important question. So Vicky, sorry to put you on the spot as a non-speaker today, but we're delighted to have your presence. The question that's come in is, do your psychologists have any role in the medication pathway? And if so, what does that look like? I'm going to pause at that because there's a second part to that. Over to you.
Yeah, well, thank you very much, Karen. I'm taking from that, are we involved in delivering care for our GLP patients? And yes, absolutely. And we work very, very closely with the dietitians and the other health coaches on the programme as a psychology team. And one of the big advantages we have with being digital is we can all see each other's notes, as well as having very close liaison. But we can see, we can see what a dietitian is writing to a patient in terms of if they're app messaging them between sessions, for example. So we know exactly what goals and what the focus is and what the issues are that are coming up. And then alongside that, we have our whole sort of psychology pathway. And we are really, I think we're quite at the forefront of learning what are those specific psychological needs of our patients who are taking a GLP-1 above and beyond what you would see in a normal tier 3 service, or should say traditional tier 3 service. What are the adherence issues and what's the role of psychology in helping people to manage those side effects and managing the impact of GLPs from a psychological perspective, because it's a whole new ball game. And of course, there's also a lot of noise out in popular culture about GLPs, which our patients are coming up against. And so it's a complex area. So we're really pleased that we're able to be there for our patients in that way and offering sort of structured psychological support around their use of the medications, as well as the usual care we would offer as a sort of experienced psychology tier 3 service.
Thank you, Vicky. So don't take yourself off mute, or put yourself on mute just yet, because a follow-up question to that, we're aware of how complex these patients are, and therefore the huge need for psychology. So one of the follow-up questions to that was, does Oviva have any experience of providing weight management services for service users in mental health inpatients or forensic settings?
Yeah, that's a really good question. And I think it's really important that within our physical health care settings that we have a quality of access for patients who have different needs, including those with severe mental illness. The NICE guidance for tier 3 services is that absolutely patients with severe mental illness should be included in tier 3 as long as their mental health condition is stable. And so we are certainly very open and have a number of patients on our books who would be classified as having a serious mental illness. So talking about things like schizophrenia, bipolar, personality disorders, those types of conditions, but they are required to be stable. So if someone's in an inpatient setting, they're less likely to be stable. And the reason that we are resistant, and we understand why the NICE guidance has that in there, is because actually, as we've been talking about, obesity is a very complex condition and requires a lot of resource from patients to make the changes that are necessary to achieve what they want to in terms of their lifestyle change. So to have that on top of trying to manage a mental health condition that's not stable is very problematic. So we do need people to be relatively stable and not at risk of, say, suicide. People are actively suicidal, for example. So it would be problematical in terms of people being in an inpatient setting. Forensics is a really, I think, interesting point when it comes to GLPs, and I'm wondering if some of our more medical team members might be able to answer that, because I suppose in some ways my traditional response, I've worked in forensic settings in sort of complex obesity weight management programs, but the challenge we always face is it's very hard for people to make changes because they don't have control over their food environment, for example, or their physical activity environment. So we can recommend things and suggest things and work with people, but it can be very limited depending on their setting. I wonder what the role GLPs might play in forensic settings where we know people have got very high needs. And I do wonder, without throwing it back to my colleagues, if anyone's got any comments about that or any thoughts.
Yes, yeah. I think it's very difficult, isn't it? Again, frustratingly, a lot of these questions are very, very good, and there isn't a definitive evidence out there. And probably what we have to do is what seems right by the individual patient and in some way make sense and build the evidence as we go. I think it'd be hard to exclude anyone, and you wouldn't want to exclude anyone because of circumstance. I think you would have to probably treat them and just make sure that you built in a very good mechanism for collecting all that data so that the next cohort could benefit from the insights that you gain. But I think that's one of the great benefits of this approach is patients in almost any setting or context can receive care where traditional services may struggle to outreach to such groups.
Thank you, Tom and Vicky. I think we've got time for one more before I wrap up. I'm aware we haven't got through all of them, but they've given us lots of food for thought for potential future webinars as well. So don't despair. We will hopefully answer them at some point. But Lucy, I'd like to end on perhaps one that shows kind of our holistic approach when we're looking after patients. So I'm going to ask you this question, Lucy, if I may. How are we encouraging and monitoring physical activity to limit the potential muscle mass loss that we sometimes see with that huge weight loss that we're expecting with GLP1s?
Brilliant question. Thank you, Henry. I saw that one and I was hoping we'd get to it. There is more and more data and evidence coming out showing that the importance of exercise during GLP-1 treatment therapy and post, and it's something I should have called out in my slides earlier. So in the initial consultation with your dietitian, very much the conversation covers exercise. So there'll be goals around exercise alongside our nutrition content as well. We've had exercise consultants come in and create content around videos, around different pathways to really support an individual on their journey throughout, regardless of which pathway. Our team have had more training around delivering care for GLP-1s and particularly that conversation on the importance of exercise. So thank you so much for calling out. I couldn't agree more.
Thank you, Lucy. And I know Juliet, who is on our call as our clinical lead dietitian in Tier 3, I had a recent discussion with her about the significance of protein and how the clinical team are really focusing on making sure that protein content is good as people try and reduce their calorie intake. We are now at time, though. Thank you so much to our expert speakers. Thank you to those that were roped into answering questions as well. And thank you to you all for your incredible engagement. We've had loads of questions come in, so I'm sorry we haven't been able to get through all of them. But if you would like to reach out, if you'd like some further conversations with us about our Tier 3 services, please get in touch. You can see our email address for our partnerships team on your screen there. It's a fancy QR code if you'd rather use that as well. We would love to speak with you about this and hopefully come and support some of your patients as well. But otherwise, thank you very much for joining us, and we will certainly let you know if we have another webinar, if and when we have another webinar planned. So thank you very much and enjoy the rest of your day, everyone. Bye-bye.